So I think my learned proponent slightly missed the title of this talk. What we're arguing about is not whether imaging is diagnostic. Nobody thinks it's diagnostic, but whether it is actually being overused. And what I want to do is make the point that, in fact, it can be very helpful to support your views on whether someone does or doesn't have a movement disorder or Parkinson's disease, irrespective of whether it helps make the final diagnosis. The clinician does not have to make use of the data, but in most cases they will, and in most cases it will provide very useful guidance. So, I believe imaging can help support the diagnosis of Parkinson's, particularly in early cases. Clearly, if a patient has been having the disease for 10 years or more, doing well on levodopa, has all the cardinal signs, it is going to be of less relevant. But most of the confusion arises early on. And here, I think imaging can be very effective, as I will show you. Most importantly, whether it makes a final disease diagnosis, what it does do if you're looking at dopamine deficiency, its presence or absence, is rationalize a trial of dopamine agents. They may not work, but it says to you there's a deficiency here, it's worth a try. Or perhaps even more importantly, there isn't a deficiency, do not put this patient on long-term agonists or dopa, which is expensive and has side effects. It may help explain the lack of drug response in patients who you're sure have Parkinson's but don't seem to respond as well as they should to dopa. And though we haven't covered this up till now, you can also, of course, image non-dopaminergic complications of Parkinson's disease and learn about them. And I would say, and something that seems to be missed out in all of these types of debates, it's extremely useful for educational purposes. If you have a patient in the clinic and they have Parkinson's disease, there is nothing like being able to show them an image of the dopamine system and an MRI and actually explain to them what's going on and why they need the treatment they need. So, are we good at diagnosing Parkinson's? You heard from one of the previous speakers that experts at Queen Square can get 99% of cases right if they adhere to the Queen Square criteria. Well, firstly, no one ever adheres to the Queen Square criteria. I defy anyone here to tell me they've gone through every damn point on that chart. Secondly, nearly all the patients, at least in the UK, get initially diagnosed in the community, first by a family practitioner, then by the local guy. He may not even be a Parkinson's expert, though many are now. And we know from 2 community surveys that there is a mismatch between eventual outcome and initial diagnosis. In this particular survey on patients who'd had the disease for at least 8 years, only 75% were thought 8 years down the line to have Parkinson's disease, even though they were all receiving treatment for that condition. In another survey by Annette Schrag, patients, we did a little better. It was something like 85% we got right. But this figure of 90-something% only applies to end stage and only applies to trained movement disorder specialists. It does not apply to real life. And it's here that imaging can make a real contribution in that 85%, in the 15 to 20% who have an incorrect diagnosis initially. Similarly, when one looks at essential tremor, a lot of these patients get misdiagnosed. Around a third in this series got misdiagnosed as having some form of Parkinson's disease and were put on therapies. Now, Angelo Antonini made the point that in his SWEDs, some of them carried on needing levodopa treatment despite having normal DAT imaging. Well, the fact is, once you put an ET patient on dopamine medicines, it's the devil to get them off because they feel better, it's a stimulant, and quite often you have to really work to get them off the stuff, and they will insist that they're worse if you try and take it away, even though there's no rationale for using it. Okay, so what sorts of imaging do we have available? Well, ideally, we'd like to image the direct pathology of Parkinson's disease, the alpha-synuclein aggregation in Lewy bodies. That is now possibly going to happen in the next year or 2. We have some agents that are synuclein selective, but at the moment we can't do it. And as a consequence of that, we're forced to look at indirect effects of the pathology, either looking at structural changes in the nigra or dopamine deficiency. Now, if you go up to 7 Tesla MRI, it's now becoming possible to detect structural changes in the nigra. There aren't many of these machines around, unfortunately, but one of the first series that came out claimed that you could pick up destruction of the nigrosome structure in the nigra with 100% specificity when they compared a series of PD with normals. Now, these results look fantastic, but obviously other people need to confirm them. And until we all get 7 Tesla machines, this is probably out of reach of many of us. Another approach is looking at diffusion tensor imaging of the nigra. Again, initial results from Chicago, David Valancourt, look fantastic. Reductions in anisotropy in the nigra of these Parkinson's patients, but with repeated series in other units, unfortunately, the story isn't quite so rosy, and the sense and spec of this technique is probably around 80%. You heard about transsonography. In expert hands, it has a high sensitivity for Parkinson's disease. It'll pick up over 90% of cases. The big problem with transsonography is that its negative predictive value is in the 70% range, which means you cannot use it to confidently exclude Parkinson's disease, only to confirm there's a nigral change in those who you believe have it. And so still, the number one modality for looking at Parkinsonian patients is looking at their dopamine deficiency. DAT scan, fluoropropyl CIT, is obviously licensed worldwide for this, and I should declare I've worked with GE on this program. Fluorodihydrotetrabenazine is another agent in development which also looks very good, but is not yet licensed. So this is how looking for dopamine deficiency can help us in practice. It does not make the diagnosis of a single entity, but it helps separate a group of conditions on the right, such as drug-induced syndromes, essential and benign tremors, from the group on the left, which are all associated with dopamine deficiency. So even if it turns out your patient does not have idiopathic PD, they have one of these other conditions, there is a rationale for trying them out on dopamine agents, and some of them will respond very well. It is, at least I've seen several cases of MSA that had great response to levodopa for some years before it eventually deteriorated. Now, the big criticism of imaging as in terms of reimbursement is how can you prove that it actually will affect eventual patient outcome by doing early imaging in these patients? And the short answer is nobody has ever managed to do that trial. You would have to image patients, follow them out for years, and see how many of them became institutionalized or not because of early imaging data being available. What you can show with imaging, there have been a number of series looking at this, and this is probably the best trial because it has control groups who had delayed imaging compared to those who had imaging at baseline, is that management plans and changes in management, changes in medication have been gracefully and significantly influenced by the ability to look at dopamine scans. So even if you don't for sure know the eventual outcome or even the eventual pathological diagnosis, you can see that 50% of clinicians were swayed once they had imaging finding in their hand and changed their management plans and changed their treatment strategies. So clearly for them, it was a very valuable adjunct. The whole question of SWEDS is very interesting. You heard the experience from Ken Marek and John Seibel in the PRECEPT study. However, the Glasgow series, where they looked at 150 cases of uncertain Parkinson's who were sent up for imaging and turned out to be normal, they found that 2 years down the line, only 3% of those were still considered to have Parkinson's disease by the Movement Disorder Clinic and the family practitioners looking after the patients. The rest had a host of different diagnoses, which you can see there. But perhaps more importantly, those patients who had normal imaging, they took a group of them, they took them off the treatment, and as I say, this was a labor of love. These patients did not want to stop their medication, but they successfully were able to stop it in all these cases without deterioration. And my guess is that 20% in the PRECEPT study who are still on medication could be got off medication with time. To move away from dopamine, we know that 80% of Parkinson's patients will eventually develop dementia, and you can pick up early cortical pathology in Parkinson's disease with simple glucose scanning, which we all have. At the moment, we don't have neuroprotectants, so you can argue about the utility of these, but it's there, and it allows you to divide patients into groups who will and who won't dement on the basis of very early cortical change. Also, you can look at other systems. You can look, for instance, at the serotonin system. We found that patients who develop undue fatigue with their Parkinson's disease, almost like a chronic fatigue syndrome, show a significant loss of serotonergic function in the limbic areas compared to those who do not suffer from this problem. And so serotonergic medication is probably appropriate here. Finally, people have talked about constipation and autonomic dysfunction with tracers like cholinergic agents. This is donepezil, which is used in Alzheimer's to treat dementia. If you label it with carbon-11, you can see in the Parkinson's cases there is a lower cardiac signal, a lower bowel signal, and a lower pancreas signal. All these areas are affected in Parkinson's disease, and in fact we're at the moment correlating gastric and bowel motility with loss of cholinergic function using this type of imaging. Atypical disease, well, clearly you can pick up strange structural changes. This is methcathinone, which was a condition which particularly affected young people in Eastern Europe who were boiling up ephedrine with potassium permanganate to make an amphetamine substitute and ended up giving themselves manganism. But most cases of MSA and PSP, as Angelo said, will not show early changes on their MRI, but if you do diffusion tensor imaging, which is available on all standard machines, you will pick up striatal and cerebellar peduncle changes, which very sensitively differentiate these atypical syndromes from typical Parkinson's disease. Or you can use FDG if you have a PET and you have someone who's interested in applying statistical mapping to the FDG syndromes. You can't do it visually, but you can do it with some of these statistical packages that are now available on PET scanners. Is data imaging ever inappropriate? Well, you've heard that if people have a good response to DOPA and established disease, you probably don't need to do it. On the other hand, we still get caught. In that first series I saw you, patients had a DOPA response and 8 years of disease, and there was still a 25% error rate in diagnosis in that community. To grade disease severity and monitor disease progression, DAT scanning is not probably useful unless you're in a research environment where you're testing out a neuroprotectant to see if it works or not. So my conclusions are that firstly, imaging is not diagnostic, but it can be very supportive, and you can look at both nigral structure and dopamine functional changes, and it will certainly help sway you mostly in the right direction if you're unclear whether this is genuine Parkinson's disease or one of the many mimicking causes. Secondly, if you're interested in non-motor complications, and they are the ones that cause most trouble 10 years down the line, you can look at autonomic function and you can look at early dementia with the imaging techniques, and you can tell which of your patients are at high risk for these problems. Thirdly, it's very easy with modern imaging to discriminate typical and atypical disease, but it does mean you have to have someone interested in diffusion tensor imaging or FDG. And finally, and something that is talked about far too little, it is very valuable when you're educating patients and carers and explaining to them what's going on in their brain and why you're doing what you're doing. Thank you very much.